Hey everyone, welcome to RegenMed Global, the podcast, where we bring you the top doctors and researchers in the world, leading the newest breakthroughs in medicine and research. My name is Sharona. Today, we're here to discuss a clinical trial and potential treatment for epilepsy. Involved in this study, we have Dr. Sharona Ben-Haim, Neurosurgeon and Surgical Director of Epilepsy at UC San Diego Health. Dr. Ben-Haim, thank you so much for joining us today.
Thanks for having me.
Of course, before we get started, can you maybe tell us briefly a little bit about kind of what you do in your background?
Sure. So I'm a functional neurosurgeon at UC San Diego. And so my primary areas of expertise involved, as you mentioned, surgery for epilepsy, which involve a really specialized set of procedures. And I'm excited to talk about that today, especially kind of what I think maybe the future of epilepsy surgery looks like. I also perform surgeries where I insert stimulators to modulate brain activity, including things like deep brain stimulation for Parkinson's disease and for tremor, as well as some other sort of emerging indications. And I also do some very specialized surgeries involving neuromodulation for chronic pain as well.
Being one of the first to do the brain cell surgery, right? Can you tell us a little bit about kind of about that procedure and just that whole trial, how that looks like?
The tools we have now often involve either resecting or ablating a region of the brain. The really exciting thing about the cell therapy, where we take cells that were derived from stem cells. Those stem cells were then turned into a very specific kind of cell that produces a neurotransmitter called GABA, which generally is a inhibitory neurotransmitter. So we can think about it as a neurotransmitter that calms down brain activity. So the whole concept now is rather than ablating or resecting a part of the brain, we could potentially now introduce this cell and actually kind of primarily calm down that region of the brain. In our brain, there are many neurotransmitters. They're sort of firing all the time. There's a neurotransmitter called glutamate, which is an excitatory neurotransmitter, and GABA is an inhibitory neurotransmitter. There are a lot of others, as you can imagine, in the equation. But in epilepsy, we do think that there is a loss of the balance between glutamate and GABA that is potentially involved in leading to epileptic activity in a region of the brain. And we see changes in these neurotransmitters, pretty specific changes, and we have these studies now in humans, pretty specific changes that happen over time in regions of the brain involved in seizures, primarily involved in seizures. And so, the idea here is really an exciting one, where we can actually go in and try to repair that imbalance and actually introduce more inhibition to hopefully make this region of the brain less prone to firing, less prone to starting seizures and having those seizures spread throughout the brain.
I mean, you did one of the first procedures of this, right? So how many patients have you done this procedure on?
So I've only done one. I think to date there have been 3 in the U.S. We have another one that's potentially coming up, and yeah, our patients doing really well. Actually, the patients in the trial so far have done quite well. So we're really, really excited, and the real thing that is unique here is that, we're hoping that with this therapy, we are able to calm the seizures down, ideally stop the seizures completely, but still maintain the underlying function of that brain region where the seizures came from. And that's not something we can really do currently with our existing therapies. So we can't do that when we resect that region of brain. We don't really get that when we ablate that region of brain, even though when we're ablating it, we do have quite good accuracy. But to kind of treat that region of brain while still maintaining function is very exciting. And so now this trial is moving into allowing us to treat regions of brain that we may or may not otherwise consider ablating. For example, the dominant temporal lobe, which is in most people who are right-handed is the left side of the brain, and usually involves the hippocampus and amygdala. That's a region of the brain where we sometimes hesitate to perform a laser ablation or a resection. We often do because we do a lot of tests to sort of ensure it's as safe as possible. But sometimes we hesitate because we don't want to cause a loss in, especially in verbal memory functions. And so with this therapy, we're really excited that we could potentially offer something where we won't see that loss, which is subtle often after these surgeries, but can be present.
With the patient or patients that at least you guys may have done the procedure on to date, what kind of results have you seen so far? What potential benefits have the patients seen?
Yeah, so our patient's doing really, really well. Because this is really new, we don't know exactly what time course to expect, for these cells to really start taking effect and integrating into the circuits and calming that region of brain. Now, of course, we've done a lot of preclinical studies that give us a sense, but I'd say we've been surprised at how quickly we've had nice results in these patients so far.
Kind of leads to my next question, like how soon could the benefits be displayed once the treatment's done, and how long do you think this could potentially last for?
Yeah, I mean, there's good reason to believe that it will last, forever. And as I mentioned, we are seeing effects even sooner than we would expect. So really, when we're thinking about surgery for seizures or surgery for epilepsy, usually, what we like to see is, what's going on at the 1 year time mark, what's going on at the 2 year time mark. We like to wait quite a while before we jump to a conclusion that this is really working. But we are seeing, and some of these patients have actually gotten to that mark, to the 1 year time mark. And they're doing really well, like really amazingly well. Even better than we expected them to do is what I would say so far as how much seizure reduction we're seeing.
Are there kind of any major risks that have stood out doing the procedure?
Yeah, so that's a great question. There are, of course, risks of the actual surgery. Anytime you do any surgery, there's risks. The approach for this surgery is very similar to an approach for like a laser ablation procedure, for example. So we're making a tiny incision and we're putting in a very small catheter into the brain, and we're injecting the cells real time, just like we do the ablations real time, to see where they are in the brain, and that the deposits are right in the region where we place them, as we would expect. So from that perspective, the surgical risk is really the same as a laser procedure, which is a minimally invasive surgery that is very safe. Now, anytime we have, surgeries for stem cells, of course, the first thing that comes to mind is to just make sure that the growth of those stem cells is regulated. For that, we feel pretty confident in our, preclinical studies where we didn't see that these cells migrated anywhere from where they were supposed to stay, where we didn't see that they replicated, to a point to any point, actually. And so we didn't see any of those risks happen at all. So we certainly don't expect that in our patients. I would say one of the hardest things, though, about being a patient in this trial, which we probably don't talk enough about, is that, as part of this trial, and this is probably out of an abundance of caution, but it is pretty standard for most trials that use cell therapy or stem cell therapy, is that patients are on immunosuppressants for a year after the procedure. So we want them to take immunosuppressive drugs for 1 year after surgery. So that's just another medication to add, to their already existing, repertoire of medications, which are often include several anti-epileptics. And those medications can be tough because we have to monitor blood levels. We want to make sure they're not, getting too high dosing or too low dosing. And so sometimes we have to do blood tests to monitor the levels of the medication to make sure that it's in a good range. And I would say that that's that's kind of a tough extra thing to have to think about for the following year after the surgery. But it really is a necessary part of the trial at this point.
How soon do you think this could be widely available for patients?
Good question. The early results are really promising. So, the trial is certainly moving forward at a really nice rate. I don't know. I guess I can't really comment too much on the time course, but I would really hope that something like this could become available more widely outside of a trial setting in something like 2 or 3 years.
About the results themselves, in terms of finalizing the results, sharing it with the general public, do you know when that would be ready?
Yeah, so we're already we're going to have an abstract at the American Epilepsy Society meeting, which is actually this week, and so that's exciting. I think that's going to be the first. I think that's the first formal publication, although don't quote me on that. Of the results of these preliminary patients. So that's really exciting, and I think that will become a publication. But of course, as the trial progresses and more patients, especially reach those endpoints, the 6-month mark, the 1-year mark, we're monitoring, of course, for seizure activity, but we're also doing what we call neuropsychological testing, which is a test of a lot of really specific functions of the brain for things like memory. These tests are there to detect very subtle changes in memory, in language, in processing speed, and all sorts of other functions. And so we're performing these tests, of course, before surgery, which is actually standard for any epilepsy surgery patient, but we're performing them at time marks down the road, because what we're really excited, what would really be kind of the holy grail here is if we see what we are hoping and kind of expecting to see and have been seeing so far, which is decreased or no seizure activity and, a maintenance or even an improvement potentially of some of these neuropsychological measures. And by improvement, I do think it's important to say that I don't think we're going to have gain of function of that region of the brain necessarily, especially function that's already been lost from seizures or from other reasons. But we do know that when you stop seizures in general, the brain performs better. And, even better when you can start to taper the medications. We're not at that point yet. But when I say slight improvement in function, I'm thinking more along those lines. At least the seizures are no longer affecting function. And then once we see those medications lift, I think we'll see some improvements.
What do you think? I mean, I know you touched on it a little bit earlier, but what do you think makes this study so unique and so important?
Yeah, so that's a great question, because I'm a part of other studies where we're thinking about injecting cells into different parts of the brain that derive from stem cells. And I'm not going to name those studies, but while I'm excited about those studies as well and the potential contribution they may have, this is a little bit different, this study for epilepsy, because in my view, it really potentially gives us a whole leap in how we treat patients for epilepsy. If this study is successful, I think it's going to really change the way we perform surgery for epilepsy altogether. And I can't say the same about other studies. I think that other studies contribute knowledge and might improve some of our existing treatments, but aren't necessarily as exciting in the sense that they could be a paradigm shift in the process. And not only that, to further that, if this works, it will also give us potential to do the things we absolutely can't do now because it's too dangerous, which is to treat multiple regions of the brain. We can do that on some small scale. We can't do that on a large scale because of just the risks associated with, potentially ablating or resecting multiple parts of the brain. And, we're more and more starting to understand that epilepsy is probably a disease not just of a focus, but of a whole network involved in the brain. So we're really understanding that maybe the future of epilepsy treatment is going to be more multifocal therapy. And we don't have a way to do that right now. And this really could potentially be that avenue.
Dr. Ben-Haim, any other kind of final thoughts or finishing thoughts that you have?
I think really one of the biggest messages that is important to send is, surgery in general for epilepsy has really seen a lot of advancements just in the last 10 years. And 10 years seems like a lot, to you or I, certainly when you think of cell phone technology and things like that. But in the world of medicine, 10 years isn't really that much time, such that, patients might have been evaluated not that long ago and been told they don't really have great options. Or, physicians might not be necessarily, might have been finished medical school 30 years ago and might not be as up to date on the current happenings in the world of epilepsy surgery, because they're still relatively new on the grand scale of things. And so I think the important message to send is, if you are a patient that has ongoing seizures affecting your quality of life that are not being adequately treated by medication, it's a really good idea to be evaluated at a level 4 epilepsy center. Because even if you've been evaluated before, things may be available now that were not available back then.
Dr. Ben-Haim, thank you so much for your time. Truly grateful for the information and feedback that you've shared with us.
Great. Thanks for having me.